Very happy to talk to you today about hypercoagulable causes of stroke in the young. These are my disclosures. I don't think any of these are pertinent. I will point out that I wrote the Stroke in Young Adult Continuum article. I guess that could conceivably be an important disclosure. Otherwise, I don't think those are important. So to give us a sort of a framework on where we're going to go today, I think it's important to talk about some of the major inherited and acquired thrombophilic states. It's a challenge in 45 minutes to talk about all of these. And so I emphasize major because, as you will see, there are no shortage of purported thrombophilic states. And then I think we should talk about diagnosis as best as we are able. This is a complicated story, and the therapeutics are complicated as well. But overall, more than anything, what I would like to do is try to establish a framework in which I will advocate for a methodical approach to investigating these patients. And I think it's a good bridge going from where we were with Dr. Singhal and to where we are going with the next speaker. So I hope that, that the order of the talks will make some sense as well. So just to give you a sense of what I'm talking about today, it may help you. I know it helps me when I know the parameters for what we're going to talk about. We're talking in this talk, we're talking about ischemic stroke only. We're not talking about ICH, we're not talking about subarachnoid, no CSVT. These patients, just by convention, we're going to say are less than 50. There's going to be what I think is a broad perspective on thrombophilias and workup, again, emphasizing the major conditions, those with the best evidence. And then also, because there were guidelines that came out last spring, 2014, we're going to put special emphasis on those guidelines as well. So in that spirit, here is that famous table that you see at the beginning of all of these guidelines talks. And so just to give you a sense, just to reiterate how these are arranged, the size of the treatment effect is arranged from left to right. Class 1, benefit much greater than risk. That's the green column. Sliding all the way over to red, the red box of death, which is don't do this, no benefit, this harms patients, etc. And then on the y-axis, then the estimate of treatment effect. So level A being the best, down to level C. Okay, so general outline for where we're going today. We'll start with just some introductory remarks. Talk about the primary thrombophilias, and I should say that I use thrombophilia and hypercoagulability essentially interchangeably throughout the talk. Talking about some secondary thrombophilias, then moving on to diagnosis and then treatment. So you've seen several cases today, and I think this helps frame where we're going. So the first case is somebody we've all seen in our clinics, I believe. And this is a 44-year-old man with everything bad that you can think of. His blood pressure is very high. His LDL is through the roof. He smoked for 25 years. He has markedly uncontrolled diabetes. And this gentleman has right thalamic infarct and more than 10 scattered T2 hyperintensity. So this is one paradigm, one sort of patient that we see who's a young patient. The second case is very different. This guy's blood pressure is perfect. His LDL is fine. He's never smoked. His A1C is 4.9. He eats grass and walks 45,000 steps a day, and you can't find anything wrong with this person. But he has what looks like a right embolic appearing MCA infarct. He has no T2 hyperintensities. So these are two very different patients, right? And so one of the things that I would advocate for is a considered approach in these patients. And I think you began to hear some of that with Dr. Singal's talk. So, as you heard already, the proportion of patients who are younger than 50 years old who have strokes is at least 10%. From the work in Cincinnati, we have seen that the incidence of stroke is increasing in the young. The reasons for that are unclear. Could just be better diagnosis, could be increasing prevalence of risk factors. And as you have already heard, these patients who have stroke at a young age are at increased risk for early death compared with the general population. You saw some of these data from the Helsinki study previously in the last talk, just to emphasize that in this cohort of 1,000 patients, that there were very high proportions of classic stroke risk factors: hypertension, dyslipidemia, and smoking. So, to put this again in context, about a third of patients who have ischemic stroke, we don't have a clear etiology on those patients, and a tiny subset of those patients are thought to have had strokes due to coagulation disorders. So, we know from work outside of stroke that patients with thrombophilic states are at increased risk for venous thromboembolism, but the evidence, and I'm going to sort of beat this like a drum, the evidence for association with ischemic strokes is not nearly as good. So the reason we're talking about this is because of these young patients, and there are any number of reasons why patients may have thrombophilic states, including genetic mutations and acquired conditions. This is the one and only time you will see this, so there are biochemists in the room, my apologies, we will not be returning to this slide. Okay, so there are all sorts of these various conditions that supposedly predispose patients to thromboembolism and, by extension, ischemic stroke. However, most of these conditions are primarily associated with venous thrombosis. The major consideration for arterial thrombosis would be antiphospholipid antibody syndrome. And so the presumed mechanism then for a patient with thrombophilia, again, this is sort of a theoretical framework, the presumed mechanism would then be paradoxical embolus, most commonly through a PFO or a VSD. However, again, the evidence base for hypercoagulable conditions in stroke is suboptimal. So let's first go to our primary hypercoagulable states. So here are the most common inherited hypercoagulable states. And here is a list of purported conditions. Now, if your training was like my training, there was some element in a young patient, some element of competition possibly, or one-upsmanship. Who can think of the most obscure, thrombophilic test to send? These are the list of purported thrombophilic states. The ones that are highlighted are the ones that we will address if only briefly. So, factor V Leiden, the most important, and I would argue by far. So this is the most common risk factor for thrombophilia. The vast majority of these are due to a single point mutation. This is actually fairly prevalent in the general population, but mostly in the white population. So 3 to 8% are heterozygous. This is very rare in non-white populations, and this mutation causes the lion's share of venous thromboembolism. There is a differential effect if you have the heterozygous versus the homozygous puts you at exceptional risk for venous thromboembolism. Factor V Leiden is also associated with multiple other thrombophilias, so not uncommon to find a patient with factor V Leiden who also has protein C or protein S deficiency, for instance. And then there are some exposures that place you at even higher risk. So if you are on oral contraceptives, if you smoke, if you're pregnant, that puts you at even higher risk for venous thromboembolism if you have this mutation. What about the prothrombin mutation? Prevalence still fairly common. This is very similar to factor V Leiden in that it is very uncommon in non-white populations. And this has not been convincingly shown, similar to factor V Leiden, this has not been convincingly shown to be associated with arterial thrombosis. Protein S is an autosomal dominant condition. Very uncommon to see a homozygote with protein S. They usually die very early. And then the heterozygotes are at risk, again, for recurrent thrombosis. Again, these have not been convincingly associated with arterial thromboses, so similar to the previous two. Same thing with protein C. This is, however, much less prevalent in the general population, with only 0.2%. Again, venous only. Antithrombin, this used to be called antithrombin 3, now called antithrombin deficiency. Again, autosomal dominant. This is seen commonly in all ethnicities. The prevalence here, very low in the general population. And then what about MTHFR? So the most common cause of hyperhomocysteinemia, and the reason hyperhomocysteinemia is a concern is because it can theoretically increase stroke risk via thrombosis, impaired thrombolysis, and then endothelial dysfunction as well, among others. This also can be heterozygous, and that's fairly common. Up to 14% of the population is heterozygous. Homozygous, the so-called TT genotype, so the three options there are CC, which is normal, the heterozygous, which is CT, and then the homozygous, which is TT, is also surprisingly prevalent, as high as 11% in the general population. And this is the genotype which is associated with the lowest folate levels. So after that brief overview, let's talk about the secondary hypercoagulable states. And here the list is very long, and we're not going to talk about most of these. These would be a different talk entirely. Much of it would be condition specific. And so in the overall framework of this talk, I think we're not going to touch on most of these. The most important of these, I think, by far for this talk would be the antiphospholipid antibody syndrome. So this is an important syndrome that can be a primary syndrome or it can be secondary due to common rheumatologic disorders such as lupus or rheumatoid arthritis. These are antibodies that bind to the membrane phospholipids. And the important thing here is that antiphospholipid antibody syndrome can cause is convincingly associated with arterial thrombosis, which I think stands in sharp contrast to the previous conditions that we've been talking about. It can also cause venous thrombosis as well. The associated antibodies here are very common to those who take care of these patients. The lupus anticoagulant, the various anticardiolipins, and then the beta-2 glycoprotein 1. So you should suspect antiphospholipid antibody syndrome if a patient has this distinct dermatologic presentation, livedo reticularis, if a patient has recurrent thromboembolism, unexplained fetal loss, if a patient has thrombocytopenia for which we do not have a clear etiology, and if they have, in the absence of other clear explanation, prolonged coagulation tests. There are several medications which have been associated with the antiphospholipid antibody syndrome as well. The other thing that I will briefly touch on here is the so-called catastrophic antiphospholipid antibody syndrome. I'm not sure if any of you have seen this or identified it. It's fairly rare for patients with antiphospholipid antibody syndrome. It's less than 1%, but it's a striking presentation. These patients become very sick very quickly. They have multiple organs that are infarcting. It seems like every day you see the patient at the bedside and something new is infarcted. I've seen only one of these patients, but she progressed rapidly to death, and there was nothing that we could do. We tried all of these things, heparin, steroids, we plasma exchanged her. Just something to be aware of if you have not come across this yet, something to keep in the back of your mind. So one of the two hardest things here is diagnosis and treatment. So what I would advocate here is for a methodical approach, and it sort of builds upon what Dr. Singhal was already working toward. The reason I think we should be methodical is that all too often, at least, I have seen sort of a cookbook approach. 40-year-old patient comes in with a stroke, and for instance, the thrombophilia workup is immediately sent off without any further consideration, without any thought. I may be alone in that, but I somehow doubt it. The reason I think we should be methodical is, based on what Dr. Singhal said, what is coming in the next talk, and that's that the results of even a standard workup can guide what we do next. So for instance, here are 4 different scenarios in which a young stroke patient presents. Case 1 is a small vessel stroke in a patient with known hypertension and diabetes, similar to one of our previous cases, right? Case 2 would be somebody who Dr. Singhal described as having neck manipulation, and they turn out to have a dissection. The next patient has no medical problems and has a right to left shunt on the transesophageal echocardiogram. And then the final patient has a stroke and doesn't have that shunt. And so I would argue that these patients are all very different. And so this may go without saying, but I'm not convinced that all of these patients require an extensive thrombophilic workup. So you can't ever do any of these talks without first advocating for a thorough history and physical exam, followed by what I think is becoming the standard with brain MRI imaging if the patient is able, which would include diffusion-weighted imaging and then some sort of assessment of bleeding, either with the older GRE or the newer SWI techniques, susceptibility-weighted techniques. I think these patients need formal angiography, whether that's through a CT angiogram or an MRA. And I think in these younger patients, I would not be satisfied simply with a carotid Doppler, just to say that explicitly. I think for these people, in the absence of clear multiple vascular risk factors or clear substance abuse-related strokes, even possibly in that circumstance, I think those patients deserve both carotid and intracranial imaging. I think for patients who are 50 and below, that I would dispense with the transthoracic and proceed directly to transesophageal There are, at times, there are people who prefer the transthoracic prior to the transesophageal, but in my mind, if I were not to find anything on a transthoracic, I would be proceeding with the transesophageal in any event. So to reduce waste and to improve efficiency, in my practice, these patients all get transesophageal echocardiograms. I think these people all need to be on continuous telemetry for the duration of their hospitalization. And then I think all of these people need at least a perfunctory laboratory workup, which would include a lipid panel and testing the urine for cocaine and methamphetamine. Okay, so you heard in Dr. Singal's talk what happens if you find an abnormality on the large vessel, a medium vessel, or possibly even a small vessel. Now we've taken that subset out. What if that workup was negative, but the patient has a PFO, something we'll talk about in the next talk? In this circumstance, I think this is an important break point. If the patient does have a PFO and there's nothing on the vessel imaging to give us a clear answer, then I think at that point we need to think about paradoxical embolism. And so I used to, at this break point, I used to just use my stamp and say I want lower extremity Dopplers and an MRV of the pelvis. And I've changed that a little bit, both based on some of what I've encountered, and then it was sort of reinforced by this study. So what kept happening to me is the Dopplers would be performed first, probably because of system issues at my particular institution. The Doppler would be performed first. In those situations, they would say, at times, this patient has a DVT, do you still want the MRV of the pelvis? And I would say, no, I have my answer. This patient has a clot, and they deserve at least 3 months of anticoagulation. And so there was a recent study which sort of backed that approach up, and this was reported at Stroke last year. And what they found in a cohort of something on the order of 140 patients who had cryptogenic stroke, that the proportion of patients found to have a DVT on the lower extremity Doppler was 7%, but in the pelvis there were only 2 or 3 patients who ended up having a clot. So much more common to find those clots in the lower extremity. And so now I take maybe even more excruciatingly methodical approach than I did prior, which is now I do the lower extremity Dopplers. If that is negative, then I proceed with the MRV of the pelvis. So say you do find a clot, and then that's sort of, at least from a therapeutic standpoint, gives you the easy button. You know you're treating these patients for at least 3 months because now you have that diagnosed clot. Either way, I think you may want to consider doing a thrombophilic workup. And so I have stratified these 9 tests into 3 groups. The first 3 are the genetic tests. And those are the tests that I think in the acute setting you can do without giving it a second thought, if we have now reached the point in the algorithm where you think it would be reasonable to check a thrombophilic workup. So that's the factor V Leiden genetic mutation, the prothrombin, and the MTHFR. The next 3 are the antiphospholipid antibody tests. Those I put in a separate category because, number 1, they're not genetic tests. Number 2, the paradigm we're talking about now is if you suspect a venous infarction. If there's no PFO and all of these thrombophilic conditions are, with the exception of antiphospholipid antibody syndrome, all of these are thought to be related to venous thromboembolism, and there's no convincing for arterial thromboembolism. then I would dispense with the venous, the tests that are associated with venous thromboembolism. And instead, I would only do the antiphospholipid antibody panel. And then the final three are problem children. And those are the protein S tests, the protein C tests, and the antithrombin tests. And we'll get to why those are the problem children here in a bit. So the problem, and this was alluded to in the previous talk, is that even if a patient has a positive test return, the reliability remains unclear. And the reason for that, at least for those three that were listed at the bottom there, is that some of these tests are affected by acute phase reactants. Patients who have inflammatory conditions, they're sick, they're in the hospital, they may be on medications which may alter the reliability of the test, especially anticoagulants. And so the problem there is that if you get a positive test, in those circumstances, you're still not sure what to do with it. And I think this is addressed very nicely in a paper by Cheryl Bushnell, who in 2001 looked at this. She was very interested in this particular phenomenon and found that about a third of patients who were tested routinely for thrombophilic states in an academic practice, a third of those were performed in a situation in which the results of the study uninterpretable. Couldn't make a call one way or the other based on whatever, medications, acute illness, etc. There was a second paper. This is a different paper, same author, same journal, same year, different paper, in which she found that the vast majority of these patients who were diagnosed initially with a thrombophilia were subsequently not confirmed. These thrombophilias were not confirmed on follow-up testing, emphasizing the difficult nature of diagnosis of thrombophilic states. So, at least when it comes to the protein C, protein S, and antithrombin question, what do we do about those? Nobody knows, of course, exactly what to do, but I think there's a general sense here that a reasonable way to go about this would be to repeat those studies 2 or 3 months down the line, have your patient off any anticoagulants that you may have them on for at least a couple of weeks, and retest in the setting of a positive test. Now, if they have a negative test on the inpatient side, I would dispense with this altogether. But then that leads to the next problem. And the next problem is, even if a thrombophilia is reliably identified, the data are still not clear on whether those thrombophilias are associated with increased risk for stroke. So there was a very nice study about 5 years ago now, which looked at multiple studies and summarized them all very nicely in tables, which I will show you. And I think this is, seeing all of the data together, I think begins to form a compelling picture, at least in my mind. So the first of these that we'll talk about just looks at the protein C, protein S, and antithrombin. And so these authors only included case control studies if they had 50 or more ischemic strokes, and there were 6 of these case control studies. And in 4 of those, the proportion of cases with the deficiency was greater than that of the controls, but none of them were statistically significant. And so this is that table. No statistical significance in any of those. Again, this is protein C, protein S, and antithrombin. What about factor V Leiden or prothrombin mutation? Again, 50 or more cases, and there are a lot more of these. There are 16 case control studies. 14 of those showed no statistical difference between those cases and those controls. And I included this, not because I expect you to be able to read it, but you may be able to see all of those NS's. I think it's just worth showing that. Very difficult to show significant difference between those groups. So then they took the next step and they said, well, okay, what if we look at case control studies? This is sort of a slicing and dicing effect, right? Okay, so the approach we didn't find anything, so what if we slice and dice? We include only those patients with PFO, and they did not find any study, again, with protein C, protein S, or antithrombin with an association between the PFO and the stroke. The studies were somewhat more mixed, however, with the factor V Leiden and the prothrombin mutation. So what about MTHFR? This has an interesting story as well. There have been 5 separate meta-analyses over the course of 10 years. The first of these stratified only by the TT genotype, and it did not reach statistical significance. The next 4 did report significant associations, generally between 1 and 2 for the odds ratios. And the risk for stroke was higher in the regions with low folate. But there were multiple methodologic problems with these. The case selection was concerning, such that in the first guideline that I'm going to cite here, this is the direct reference. The guideline authors give this the red box of death. Don't routinely screen ischemic stroke patients for hyperhomocysteinemia. With recent stroke, this gets a class 3 level of evidence, C, and this is new in 2014. Next, I included some direct quotes from the guidelines. The first of these is that the evidence for all of those thrombophilic conditions, the evidence is most developed for factor V Leiden and for MTHFR. And then they follow that up with the evidence is still not strong, even for those. The next line, I think, is very telling, in which they say the evidence is very weak or non-existent for prothrombin gene mutation deficiencies of protein C, protein S, and antithrombin. So fairly straightforward guidelines quotes here. So this, I think, led the guideline authors to say, we're not completely sure, and I think with good reason, just based on the evidence, we're not completely sure that ischemic stroke patients should be screened for thrombophilic states. Now, this is only class 2, and the level of evidence is very low, but I think there was some legitimate concern on the part of the guideline authors. What about for the antiphospholipid antibodies? So again, they recommend not routinely screening these patients if they don't have anything else that would be concerning for antiphospholipid antibody syndrome. They don't have livedo reticularis. They don't have abnormal coag tests. They don't have multiple losses of pregnancies, etc. And again, that's a class 3 level of evidence, C. So I think most people are recommending a tailored approach. Most people are saying, let's select those people who are at the highest risk, and sort of the paradigm we've been trying to establish here. If people are younger, okay, that's what this talk is about, right? If there is an unclear, undetermined cause of the stroke, if this patient has a family history of venous thrombosis, or a personal history, or multiple miscarriages, etc. And then finally, one point here is that a fair amount of this talk has to do with waste and efficiency. And this is really old. This is 15-year-old data now. But in addition to other potential harms that the patient may experience, whether that's something reasonably trivial like additional blood work, or if it's something more significant like a patient being possibly placed inappropriately on an anticoagulant based on an unreliable thrombophilic workup, there are still costs. And so this is, like I said, older data, and even back in 2001, for what I would regard as a partial thrombophilic workup, at least now in 2015, the costs were $2,000 at the time. And I think that's, worth at least one slide just to talk about costs in this situation. Okay, so what about treatment? You may find this dissatisfying, but the best regimen for treatment, if the diagnosis is difficult, the studies essentially have not been done for treatment for these patients. So we don't know the best way to treat most of these thrombophilic states. There are very few large trials to help us. We also don't know not only whether they should be treated, we also don't know how long to treat them. So I think multiple problems there. And then finally, sort of to get back to that previous slide, whether that ratio, that cost-benefit ratio, will actually work in our favor and in the patient's favor, I think is unclear. So the first of these guidelines is on what they term the hypercoagulable states. And again, they reiterate that we don't have the trials, essentially, to tell us the answer. So one of the first recommendations they make is that you may consider anticoagulation. And I guess I should say that I think it's fairly common, at least in the various institutions that I've trained in or worked in, that patients with what were thought to be clear thrombophilic states were, at least in the short term, started on anticoagulation with that justification that this patient had a stroke once, they likely are at risk for having another one. Maybe not perfectly supported by the evidence, but that was the general sense. So in the guidelines, the authors wrote that they thought this was a class 2 with a level of evidence of C. So not, in my view, a compelling indication, certainly to place these patients on anticoagulation. But again, they say that it's considered sort of similar to what we heard previously. It may be reasonable to place these patients on anticoagulation. If, however, and I think this probably goes without saying, and that's likely why it got a 1A recommendation. If, however, the patient is not started on anticoagulation and they do have what is thought to be thrombophilia, then those patients should be started on an antiplatelet. And I think that probably goes without saying. This next one I include not for the first part, because again, we're not talking in this particular talk about CSVT, but if a patient has a recurrent stroke, again, of unclear etiology, and it looks as though they have a thrombophilia, then long-term anticoagulation might be reasonable, although again, level 2, level C, same sort of degree of strength of the recommendation. An interesting story on the antiphospholipid antibodies. There's no clear consensus on which way to go with these patients. In Lupus, the journal Lupus, 4 years ago, there was a report from the International Congress on Antiphospholipid Antibody Syndrome. And interestingly, the authors could not agree. That's why it was non-graded. They couldn't even agree on what, it didn't even reach the consensus agreement phase, but they went ahead and put it in there, and they said that they recommended either high-intensity warfarin with an INR of greater than 3, or warfarin, an INR between 2 and 3, plus an antiplatelet. there are no trials for this, and scarce support for that. And so the guideline from the Stroke Association was that if a patient does have antiphospholipid antibody syndrome, they don't meet that criteria for antiphospholipid antibody syndrome, the clinical criteria, the degree of suspicion that is, then you would treat them essentially like you would treat any other patient with a non-cardioembolic stroke. They would get an antiplatelet, and that got a class 1 level of evidence B. However, I included both of these together because I think it's not worth splitting them up. To see them together, I think, tells a better story, and that is that if the patient does meet the criteria for antiphospholipid antibody syndrome, again, not the laboratory one per se, but the clinical one, that it might be reasonable to anticoagulate these people. If you don't anticoagulate them, then those patients need to be on antiplatelets. Again, sort of goes without saying, but that's why it gets a 1A. There was a very interesting study that I will just touch on in the New England Journal last year, looking at purported mechanisms for injury in antiphospholipid antibody syndrome. So there are sort of two processes. The first is thrombosis, and that's the one that we're trying to tackle with antiplatelets or anticoagulants, and that's to the left of the screen. And then to the right of the screen is this this concern that these patients, and you know, we're brain focused, but these patients also have renal problems as well as other vascular problems. And so what this paper did is it did two things. Number one, it hypothesized based on some of their experiments that this mTORC pathway was responsible for the vasculopathy found in antiphospholipid antibody syndrome. And then the second thing that they did is they actually ran a study. Now this was based on renal transplant. And what they found was that 70% of the people who got sirolimus, their renal allografts were functioning fine at several years after transplantation. 70% compared with 11% in the patients who did not get sirolimus. So I think there's some emerging, exciting, you might say, developments possibly in the treatment of antiphospholipid antibody syndrome, because you didn't see sirolimus on that previous list of treatments for antiphospholipid antibody syndrome. It was more Plex, steroids, etc. So I think that's an exciting development. And then finally, we could have an entire 45-minute talk on MTHFR and homocysteine. So we previously said the guidelines say don't routinely test these people for hyperhomocysteine. And then you get more of the story here, which is that patients who have, even if you're not supposed to test them, if you do find that they have elevated homocysteine, that it's reasonable to supplement them with vitamins because it'll reduce their homocysteine, but it won't prevent any strokes. And I think this is a story well known, at least in the stroke community, that you can lower the homocysteine, but it won't. At least thus far, it's not been shown to prevent stroke. Now, you may have seen an exciting study out of China here in the last couple of weeks, in which, at least I think for the first time that I'm aware of, they stratified these patients. They stratified them by their genotype. So they stratified by CC, CT, and TT. And so I think that's a step in the right direction. Actually, it addresses a specific question in the guidelines from 2014. So I think that's a step in the positive direction. But at this point, I don't think, based on one study, that we can advocate for a substantial change in approach. So with that, just briefly in summary, there are several conditions which purportedly put patients at risk for ischemic stroke. I think that testing these people unselected, I hope I've made it clear that I'm concerned that testing these patients unselected, I think, is low yield, problematic, expensive, and inefficient, and that I think a tailored approach is the way to go. I think this is challenging, controversial. I am not convinced thus far by the studies that we have that there are associations between thrombophilic states and ischemic stroke, and the best treatment regimen for most of these is uncertain. I will, in closing though, say that I think the future is I think as we improve our studies, as we get larger studies, as we begin to stratify people. For instance, as an example, this MTHFR folate study out of China. There's another study that just recently came out in atherosclerosis, stratifying Prothrombin G20210A patients by smoking, and found a very interesting interaction there. I think as we improve our phenotyping, as we genotype more of these patients, I think we're going to begin to find how to slice and dice these data, slice and dice these patients to identify those patients who may actually benefit from targeted therapy for the thrombophilia. I think we'll get there. So I'm not sure we're there yet, and so that leaves some uncertainty about exactly the best way to treat these people. But I do have some hope for the future that we will be able to better identify those patients with true thrombophilias that are placing them at risk for stroke, and better ways to treat these people. So with that, I will thank you for your time, and I'm happy to take any questions.
So patients who are identified with this thrombophilic states, and especially antiphospholipid syndrome, anticoagulants are chosen. And is there any data or role of oral, the newer anticoagulants, as compared to the
No. We are in a data-free zone. There are, as far as I know, no data to be found. There's certainly, at least in my mind, no convincing data.
Thank you.
What's the indication or the role, the indication for the placement of an IVC filter in patients found to have a DVT in the setting of a PFO? So the first question, unless you plan to keep the patient on lifelong anticoagulation, of course. And then the second question is that how do you work up a patient for an intrapulmonary shunt?
So taking the first question, or I'm sorry, taking your last question. That can be a bit of a challenge. I think the first step that I would generally take is I usually start with a CT of the chest, with and without contrast. And if there are any concerning findings there, then I would generally ask for some pulmonary assistance on that. So that's the second question. The first question was something about a filter. Yeah. So if I were convinced that a patient had a true thrombophilia and had and in your question, did they also have a PFO? Yeah. They also had a PFO. Okay. So at that point, I would be inclined to request assistance with a filter. Now, the question is always, how much risk are you willing to tolerate? Some people would say those patients need to have their PFO closed, and I want if they can have their PFO closed, then they won't require prolonged anticoagulation, but still places them at risk for PE, in my mind. So I think putting a filter in for the short term would be reasonable. I don't know the data on how long to maintain those filters, to be candid.